So what is cleft lip and palate? These are the most common congenital anomalies of the orofacial region. They can occur either isolated or together in various combinations or along with other congenital defects, particularly congenital heart defects. Cleft lip is defined as a cleft of structures anterior to the incisive foramen. Here is your incisive foramen, and structures clefting anterior to this are called cleft lip. It can be complete, that is involving the alveolus, incomplete, or unilateral or bilateral. Cleft palate is clefting of the secondary palate, and this also may be incomplete, complete, bilateral, unilateral, or submucous. Cleft lip and palate and isolated cleft palate, which is also known as cleft palate only, are unique in both the etiology and epidemiology. The classification, many classifications have put forward classifying the cleft lip and palate. The oldest classification being View's classification of 1931. It has 4 groups. It has divided the different types of defects in 4 groups, ranging from defects of soft palate only to complete bilateral clefts. But the drawback of this classification is that it has no provision for isolated cleft lip, which is also an entity. So then, in 1950s, Carnahan and Stark proposed this classification of striped Y, which was based on the incisive foramen. This oval represents the incisive foramen, and then structures are blocks are numbered from 1 to 9. Here, the involved areas are shaded, and the uninvolved areas are not shaded. So Carnahan and Stark proposed this classification in 1950s, but in 1971, Carnahan modified this. And there he proposed this system based on intraoral view of the palate, where he proposed this Y diagram marked from 1 to 9, where the involved areas are shaded and marked according to the extent of clefting. Then we have the most common Larshall system, which is a paraphrase for clefting of lip, alveolus, hard palate, soft palate, and again going towards hard, alveolus, and lip, the Larshall. So here the areas are again subdivided into lip, alveolus, hard palate, soft palate, and it involves recording the cleft status starting from the right side. Right side, lip, working back to the soft palate, and then forward again on the left, marking each area as complete or incomplete cleft or no cleft. Then the incidence, the overall incidence of cleft lip with palate is 1 in 1000 live births. Heba, how to remove voice notes, I am not sure. The NB team will guide you. And isolated cleft palate occurs less commonly in 1 in 2000 live births. Cleft lip and palate both are typically more common, occurring in 45% of the cases, whereas isolated cleft palate is fairly common, present in 40% of the cases. Cleft lip alone is less commonly found, present in 15% of the cases. Many epidemiological studies have revealed that if a parent is affected with cleft, they have a 3.2% chance of having a child with cleft lip or palate, while a 6.8% chance of having a child with isolated cleft palate. So the etiology can be genetic, that is associated with syndromes, or non-syndromic, and non-genetic, that is depending upon the environmental factors. Environmental factors like maternal smoking and consumption of alcohol play an important role, especially when the exposure has been in the first trimester. Then increased parental age, maternal obesity, more than 30 BMI, pre-pregnancy diabetes, maternal hypoxia, stress during pregnancy, decreased blood supply in nasomaxillary region. Also, folic acid deficiency, exposure to drugs like anticonvulsants, folate antagonists, retinoic acid also has been implicated. if the fetus is female, then cleft palate only is more common, whereas cleft lip with or without involvement of cleft palate occurs more commonly in males. In genetic, cleft palate only is more commonly associated with a syndrome, whereas cleft lip and palate is associated with a syndrome only in 30% of the cases, whereas in cleft palate only 50% chances are of a syndromic association. Now there are more than 300 identified syndromes. The most common being a deletion on the long arm of the chromosome 22, that is Bridgewater syndrome. This interstitial deletion has a prevalence of 1 in 4,000 live births. Its transmission is autosomal dominant, but it has wide phenotypic expression so that approximately 50% of these will have a cleft palate abnormality, most commonly cleft palate alone or a submucous cleft. Then these are the other syndromes associated with cleft lip and palate: Waardenburg, Treacher-Collins, van der Voort syndrome, ectodermal dysplasia, Zollinger dystrophic dysplasia, and Gorlin syndrome. Non-syndromic clefting accounts for 70% of the cases. It is multifactorial. It may have a known or unknown cause. Now, variants of interferon regulating factor 6 gene, that is IRFS6. This has been also implicated in van der Voort syndrome, here IRFS6. But some variants have been implicated in non-syndromic clefting also. Apart from this, other associated genes like transforming growth factor alpha 133, MSX1, and fibroblast growth factor receptor FGFR gene, etc., have been implicated. So these are the syndromic and non-syndromic causes of cleft lip and palate. Now, to understand how this clefting happens or why it happens, we'll have to look at the embryology or the development of the face. This is a small video which I'll play, and here you can see how the face develops.
Many of the structures of the face vary early on in pregnancy, beginning around the 4th week after conception. Many of the structures of the face originate from a group of cells called cranial neural crest cells. These cells move in a distinct pattern from the neural tube located in the back of the embryo to create the various structures of the face. Aberrations in the formation or behavior of these cells are the main causes of abnormalities in the head and face. During the first 3 days of development, the fertilized ovum, or egg, is located in the fallopian tube. As it travels down the tube, it undergoes rapid divisions to form a cluster of cells called the morula. These cells then organize themselves to form the blastocyst, and by the end of week 5, the fully formed blastocyst comes into contact with the uterine wall for implantation. During the 2nd week of development, the inside of the blastocyst, known as the embryoblast, becomes 2 layers, the hypoblast and the epiblast layers. Together, these layers form an oval-shaped disc-like structure. In the 3rd week of development, a streak is created on the surface of the epiblast, during which time the cells of the epiblast detach and migrate. These migrating cells create 3 layers, the ectoderm, mesoderm, and endoderm layers, which go on to contribute cells to form all the tissues and organs in the human body. In the 3rd to 4th weeks of development, a cord called the notochord is formed. This induces the cells in the overlying ectoderm to thicken, forming a region called the neural plate along the back of the embryo. The edges of the neural plate elevate to form the neural folds that eventually fuse to form the neural tube. During this process, neural crest cells are formed along the entire length of the tube at the tip of the folding neural folds. Neural crest cells formed from the head or cranial region are called cranial neural crest cells, or CNCCs. These cells multiply and soon start migrating over long distances in distinct paths from the back of the embryo towards the front of the embryo. Once they arrive at their target destinations in the facial regions, CNCCs further develop and mature and ultimately contribute to a substantial amount of the structures in the head and neck region, such as bones, cartilage, and nerves. Growth, migration, and subsequent differentiation of CNCCs are critically important for proper development of the normal structures of the facial region. Soon after the CNCCs reach their final destination, the facial structures begin to take shape externally. By the 4th week of development, the embryo is characterized by 5 facial swellings: the frontonasal prominence and the paired maxillary and mandibular prominences. These structures are formed in part from the migration and proliferation of the CNCCs from different regions of the neural tube. In a 5-week-old embryo, the nasal placodes, which will go on to become the olfactory system, and the optic placodes, which will become the lenses of the eyes, will form. In addition, the maxillary and mandibular prominences enlarge and grow forward and towards the middle, eventually giving rise to the upper and lower jaws, respectively. In a 6-week-old embryo, the 2 mandibular prominences fuse to form the lower jaw. At this point, the outline of the mouth is visible. In the 7-week-old embryo, the maxillary prominences grow and fuse to form the border of the nostril and the upper lip. Merging of the maxillary and mandibular prominences forms the cheeks and the corners of the mouth. The philtrum of the upper lip and palate are also created at this time. In this flurry of activity in the first 7 weeks after fertilization, the 5 facial prominences give rise to the formation of the forehead and sides of the face, middle and sides of the nose, the philtrum, the upper lip, the palate, and the lower jaw. By the 7th week of human embryonic development, most of the facial structures can be observed. In the next few months of development, the initial cartilaginous skeleton of the face is replaced by bone, and there is an overall increase in shape and size of the different structures of the face. From childhood to adulthood, the face continues to develop through further growth and remodeling.
So now you understand that the failure of fusion of the frontonasal and maxillary processes results in a cleft of varying extent through the lip, alveolus, and nasal floor, which can be unilateral or bilateral. Then there is a microform cleft which appears as a small dent in the red part of upper lip. While cleft palate happens when there is failure of fusion of the palatal shelves of the maxillary processes. Now I'll show a small video which will explain this development of palate better. As in the previous video, focused on development of face only. So this also has, I'll focus on the development of palate part. Yes. It does not have voice. So just focus on it has coronal section and lateral section. See how these palatine processes are growing, and then they will turn horizontal and fuse with each other to form the palate. See, now they have turned horizontal and fused to form this palate. So failure of this process to happen results in a clefting of the palate. This is a video depicting the different types of cleft lip and palate. This will explain to you the different types better. Bilateral complete, unilateral complete, cleft uvula, unilateral cleft palate, bilateral cleft palate, then unilateral cleft lip anterior, full palate, and a full defect. So now, what are the problems you will associate? What are the implications of this clefting? Why can't we leave it alone? The problem, as obvious, is cosmetic due to the visible deformities. Then, is it only cosmetic or it goes deeper? Yes, why not? Feeding. How will the child feed? The child has difficulty in suckling because of lack of suction, because of the gap present in the roof of mouth and lips. Then there will be dental problems also, like natal teeth, microdontia, toroodontism, ectopic eruption, delayed tooth development. Then what else? Speech and language difficulties. Abnormal nasal resonance and difficulty in articulation will be there, which will lead to difficulty in language acquisition, both expressive and receptive. Language acquisition is delayed. Ear diseases and hearing. Frequent ear infections because of the patulous eustachian tube will cause will might lead to otitis media with effusion, which will result in hearing loss, which will further contribute to delay in speech acquisition. All this might and do lead to psychosocial issues in the child, which impact the child's self esteem, behavior, and social skills. He may develop feelings of anger, fear, sadness, and alienation from peer groups. So, what do we have to do? We have to manage it. We have to prevent it. Nowadays, prenatal diagnosis of cleft lip and palate has allowed around 75% of children to be picked up as early as 13 to 16 weeks gestation by ultrasonography. Isolated cleft palate cannot be seen as easily. So, in this, the role of prenatal fetal MRI is being evaluated and it might become more frequently available in the future. Now, if their prenatal diagnosis has been done, the child's parents can be referred antenatally to the cleft team who can provide them proper guidance, what to expect, how to feed the child, what will be the expectations of treatment protocols, and also refer them to the appropriate parental support groups. Children with a cleft lip and palate may be able to breastfeed with help or the use of specialized bottles help as where it creates the ability to create a vacuum and enables child to suckle milk. Management of this cleft lip and palate. Care of a child with cleft lip or palate is a complex, highly specialized and lifelong undertaking. So it is important that this care is addressed in a multidisciplinary setting in order to allow adequate attention to all aspects of care and subsequently improve outcomes. Input is needed from a cleft surgeon, an ENT surgeon, pediatric dentist, speech therapist, audiologist, orthodontist, psychologist, geneticist, and a pediatrician also should be involved in this team. Before surgery, nasoalveolar molding devices have been used recently. It was designed firstly by Grayson et al. In 1999, and since then it has been used. It is an infant orthopedic device which reduces the severity of cleft deformity and moves the nasal alar base into a more favorable position. As you see, this is an example of this device. It uses this plate goes into the mouth, and these are the nasal stents achieved, which will pull it together, and then they are taped to the face for stronger grip. This device is fitted as soon after birth as feasible and should be worn full time. It has to be regularly adjusted to alter the shape and length of nasal cartilages and columella because surgical management is complex and tailored to the individual deformity present. If there is only cleft palate, then it can be dealt with as soon as 3 months. Generally, the rule of 10 is applied as with any other surgery. Rule of 10, that is, the child should be 10 weeks of age, 10 pounds of weight, and having 10 grams of hemoglobin. So, in general, this is a broad timeline of the surgeries which are done. That is primary lip repair along with repair of the nose and hard palate between 3 to 6 months. Between 9 to 12 months, the palate can be repaired. Secondary speech surgery, if required, has to be done between 4 to 5 years, and alveolar bone graft between 8 to 10 years. Secondary rhinoplasty is delayed, usually till the facial skeleton growth is completed by 15 years. So it has to be done between 15 to 18 years, and likewise any orthognathic surgery after 16 years only. Now, lip repair. Lip repair addresses both functional and cosmetic problems. Lip is generally repaired when the child is 3 to 6 months of age, as we saw in the timeline, along with the hard palate and primary nasal surgery, depending on the requirements. The aims in both unilateral and bilateral cleft lip repair are similar: to achieve primary muscle continuity and to reconstruct the lip elements to give a symmetrical appearing Cupid's bow with minimum scarring. Uh, Sometimes some people are now they are doing neonatal lip repair also, but as of now, there is no firm evidence that it provides some additional aesthetic or functional benefit. So we follow 3 to 6 months of age repair only. There are multiple approaches to reconstructing the skin of the lip. The Millard repair and its modification, and the Fisher repair are the two most commonly practiced ones. This is a video of the animated video of the lip repair being done. Please see. Yes. Functional continuity of the orbicularis oris is restored, and then skin is sutured, keeping in mind the vermilion, Cupid's bow, and other landmarks. See the difference before and after surgery. Palate repair. Palate repair consists of hard palate repair and soft palate repair. In hard palate, the timing varies between centers where they way between early palatal closure, which will help speech, and delay hard palate closure, which will improve facial growth. So, the common practice is to close the hard palate with a Vomerine flap at the time of lip repair. Or if the cleft is not complete and there is no cleft lip, there is only isolated cleft palate, then it will be repaired at the time of soft palatal repair only. Soft palate repair. The aim of palatoplasty here is to reorientate the palatal muscles. What are the palatal muscles? Levator veli palatini, palatopharyngeus, and palatoglossus. Then tensor veli palatini is there, but its major function is to open the eustachian tube only. So here in the palatoplasty, we focus on these three muscles. The aim of palatoplasty is to reorientate the palatal muscles and to achieve lengthening and improve movement of the palate, and also create adequate velopharyngeal closure. Adequate velopharyngeal closure is important in these children because these children already have this 22q deletion. So in such kids, the postnasal space itself is deep. So while repairing, we have to keep in mind that even after repair, there is no velopharyngeal gap or velopharyngeal insufficiency. There are various surgical options available, like von Langenbach, furlough double opposing Z palatoplasty, Bardak 2 flap palatoplasty, View-Wardell Kellner V2Y pushback, and Somerlad's technique. I will describe these Somerlad's technique and furlough double opposing Z palatoplasty. Somerlad's technique has been favored because it has advantage of using operating microscope to perform the surgeries. Now, when you use operating microscope, it will provide better magnification and superior visualization. So here the incisions are made close to the soft cleft margins on the oral side of the junction between nasal and oral mucosal surfaces. The incision can be extended to the posterior hard palate. Then dissection of the mucoperiosteal flaps is followed up to the greater palatine vessels and distally up to the posterior edge of the hard palate. Then dissection of oral mucosa, investing the musculature velum is done. Then dissection of the palatal shelves, nasal mucosa, and careful approximation in the midline is performed. As you saw in the embryology, how the palatal shells are closing. So in the same way, small sutures are placed to close the palatal shells which are separate. Then, after adequately mobilizing the muscle, the Tensorvelli palatini palate sling is reconstructed using mattress sutures or interrupted sutures. Then, suture approximation of the oral layer completes this repair. Perlow's double opposing Z palatoplasty is also done. Details, I'm not going into details. Then, intravelar veloplasty is all is mostly combined with either of the technique, because in this there is reapproximation of the disrupted palatal muscle sling. This improves this will improve the velopharyngeal function, which is very important to prevent aspiration, to have a good voice, denasal voice, normal resonance, and to avoid feeding problems. It is carried out via incisions along the soft palate cleft margins, as in the Somerlat's technique. Then, after the cleft margin incisions are made, careful dissection is made of the muscle from the nasal and oral mucosal layers. The muscles are then detached from the palatal shelf, realigned and sutured transversely to form a sling. Here you can see the difference after surgery. Obvious difference. And these are the adjunctive surgeries which are required: nasal surgery and alveolar bone grafting. Nasal surgery aims to improve aesthetics and nasal airflow with the minimum of disruption to facial growth. Cleft nose deformity is characterized by asymmetric nasal tip, deviated nasal septum, and asymmetry of the nasal bones. So, timing of nasal surgery, as I described before, also it is controversial. Sometimes it is done primarily along with closure of the cleft lip, whereas in presence of complex deformities, definitive rhinoplasty reserved till facial skeletal growth is complete, that is after 15 years of age. Then alveolar bone grafting. It is also done as a secondary procedure to stabilize the alveolar arch and allow eruption of the lateral incisor and canine into an optimal position. The timing of bone graft is determined by the development of canine tooth. Although earlier may be indicated to support eruption of lateral incisor, but still primary bone grafting in some series has indicated significant growth impairment. While when we did it as a secondary procedure between 9 to 11 years of age, no detrimental effect was found. So, alveolar bone grafting is preferably done as a secondary procedure. Now, velopharyngeal insufficiency. Special mention has to be given to this because of high chances of velopharyngeal insufficiency. 40 It is found in approximately 40% cases of cleft lip and palate or cleft palate alone cases. So, where anywhere in any syndromic children or anywhere where there is an indication, the child should be evaluated, preferably in a multidisciplinary environment, to rule out or rule in velopharyngeal insufficiency. The investigations of choice are flexible nasal endoscopy and speech video fluoroscopy. Then management will depend upon the underlying symptoms and size of location of velopharyngeal gap. If the gap is small, then it can be treated by palatoplasty alone, like in the case of a submucous cleft, or re-repair where there is evidence that the levator muscles do not have a transverse sling and they are in an anterior insertion. So there, this palatoplasty might help. Uh, it has a lower morbidity than a full pharyngoplasty. But pharyngoplasty has to be done where the gap is large, because pharyngoplasty allows us to alter the shape of the velopharyngeal port to allow full closure on speech. This can be done either by using flaps from midline of the pharyngeal wall or medial transposition flaps from the lateral pharyngeal wall. Both types of pharyngoplasty have been shown to improve speech outcomes with the possibility of achieving normal resonance in up to 85% of cases. But yes, this pharyngoplasty has more morbidity also. It has high chances of sleep apnea. So this thing should be communicated to the patient and their family that sleep and development of sleep apnea is a drawback of undergoing pharyngoplasty. So always we have to weigh our options. The the benefit is more or the harm is more. So we choose our options accordingly. Now, the key points to remember from the discussion is that clefts of the lip and palate are common congenital birth anomalies. Etiology is multifactorial. Known associations are with maternal smoking, alcohol, and antenatal anticonvulsants, especially in the first trimester. Prenatal screening for cleft lip and palate is now routinely available in many centers, and the management requires a multidisciplinary approach to ensure the best outcomes. As an adjunct, I would like to uh, remind you or present before you about the Smile Pinky and Smile Train. Smile Pinky is an Academy Award winning Best Documentary which showed the heartwarming and true story of brave Indian girl Pinky who waited 6 long years of life changing cleft surgery. Now, this is so common, but still, you think why they had to wait for 6 years? Because uh, the parents were uneducated. She was born in a village, and the parents, or even the whole village, had no idea that this can be treated also. One day, a social worker visited their village and he told Pinky's parents about the free cleft treatment program for the poor. And then they went on to find the Smile Train's local partner in Banaras. And there also, they had a waiting time of 6 years. Uh, but then it gave her not only a new smile, but a second chance at life. This is the flyer of Smile Pinky. You can find it on YouTube still. If you are interested, Smile Train is an international children's charity with a sustainable approach. Uh, it uses the teach a man to fish and you give man fish and you feed him for a day. If you teach a man a fish, you feed him for the life. So Smile Train uses this methodology, this model, and it focuses on training local doctors to perform cleft repairs in their communities. These doctors then go on to train other doctors. This creates a chain phenomenon, creating a long-term sustainable system of alleviating this problem. These are the social media handles of Smile Train. These are the suggested reading. You can have a broad plastic surgery in people who are more interested in repair details can go for this chapter. And for a basic reading, you have to read the Scott Brown's chapter 18. So finally, I would say, did you smile today? Don't forget to smile. Be the reason someone smiles today. Thank you. I hope the talk was fruitful for you. Any questions, sir? My lecture is complete. I would like to take any questions. Uh, Share this video. I don't know, means all the videos are available on the YouTube. I have taken them, I have embedded them from the YouTube. So you can just search Cleft Lip and Palate. There are so many videos. There are bigger ones also. I don't know if you are provided with this link of the presentation, then the NB people will do so. Surgery. Surgery is step 5 always. It depends, actually depends upon the defect. If it is only a cleft lip, then initial the initial surgery is done at the age of 3 months, beginning between 3 to 6 months of age. But then this will also need revision, because as the child grows, the scar will also grow. So what cupid bow uh, symmetry was there at 3 months, that might not look very symmetrical at the age of 12 years. So scar revision and multiple surgeries are required. And if you talk about cleft lip and palate, along with means a big defect, bilateral defect, that is also closed, that will require a number of surgery that cannot be treated in one single surgery, because in that also cleft lip will be closed at the age of 3 months, then palate at the 9 months, and then different surgeries like if there is velopharyngeal insufficiency, that will be done along with soft palate repair, that is pharyngoplasty, or a vomerine flap is given at the age of 9 months. Then when the child grows, then definitive surgery is done, nasal alveolar bone grafting at 8 to 10 years of age. And other, I had shown a slide showing the timeline. I will wait a minute, I'll share it again. You can take a screenshot. See, so the surgical management is complex and it is tailored to the individual deformity present. So this is the timeline of various surgeries. All right.
So, dear trainees, we still have time. So, you may type your questions, comments in the chat box. That will help you to clarify your thoughts and those of the others too. Thank you.
Mm-hmm. Recommended weight. Yes, the minimum weight should be 10 pounds, that is 4.5 kg for the child for any surgery. So that is followed in the cleft lip repair also. Best surgery. Best surgery is in cleft lip. The most commonly used surgeries technique is the Millard repair. Millard repair, and then different types of Z plasties later on to use for scar revision. And in palato in palate repair, the two I told na, Somerlad's technique and the Furlow's technique of Z-plasty. These two are most commonly used, along with intervelar veloplasty. Intervelar veloplasty is for the reconstruction of levator sling only. So this can be combined with any technique of palate repair. Uh, Sir, do we have to share the slides? Do the students get these slides?
Ma'am, you can mail us on our mail ID, ma'am. We will send you.
All right. Can you repeat long leg and back surgery? Okay. Can you? I'll answer the previous question. Can you repeat von Langenbach surgery? Why will you repeat? See, von Langenbach surgery is mostly freshening of the margins and closure. So once you have done it, you need not repeat it. Any surgery. Then you have to deal with the complications or the things which were not dealt in the previous surgery. When you are operating on a 9-month-old child, suppose the primary palate repair has been done at the age of 9 years, then if you have used this one Langenbeck technique, you have closed it nicely. But then further course depends upon the child's development also. There can be wound dehiscence, the musculature could not develop normally, it would not gain strength, there is still velopharyngeal insufficiency. So these are dealt according to the complications or according to the problems that the child encounters later on in their life. All right, if the palate remains short, for the soft palate falls short, so then the lengthening procedures, that is the Somerlat's technique or Z plasties, those surgeries are used. All right, the treatment and the surgeries, especially, they have to be individually tailored. As in rhinoplasty. See, rhinoplasty is not one surgery. How to close bony defect in between? Do we take some graft? Bony defect? No, I have not read about use of any bony graft. Bony dentition to support the alveolar arches after the child develops.
Yes, ma'am. Ma'am, there is one more query came. Dr. Deepti. I think we lost. Ma'am. Ma'am. Actually, we lost you, ma'am. Can't hear you, ma'am. You're not audible. Ma'am, you are not. Can't.
It is syndromic child. Very low chances of.
Ma'am,
Yes.
I think if for almost 1 or 2 minutes you were not audible, ma'am.
Oh, okay. Yeah, I was asking. Am I audible? Okay,
Okay, ma'am.
fine.
Yeah, ma'am. Now you are audible.
All right, thank you. So answering Avinash's question, if diagnosed intrauterine, then termination of pregnancy or repair after birth. See, mostly cleft lip is diagnosed. So, as I told in my presentation also, it just intrauterine or prenatal diagnosis helps in the gives you an armor. Ki yes, you know what's going to happen, so you will be better prepared for it. So that gives us time to refer the parents to a cleft team, multidisciplinary team, so that they can plan and they may know what to expect and what to do about it. Okay, but termination of pregnancy, we would not think unless it is very, unless there are presence of other malformations like when it is syndromic along with congenital heart diseases and the child will be difficult to subsist on his own, then maybe termination of pregnancy might be considered. But presence of just cleft lip is not an indication for termination of pregnancy, I guess. And about Anubhav Goel's question, how to close bony defect in between? Do we take some graft? Yeah, bony defect is not. No graft is used. Just the mucoperiosteal layers, muscular layer, and the mucosal layer. The closure is done in 3 layers only. But later on, when the child develops, and there are defects like in the nasal floor or saddle nose or all other deformities, and the alveolar arch has not developed well, so that the eruption of teeth have not happened well, then alveolar bone grafting has to be done. And this, while doing rhinoplasty also, we augment along with cartilage or bone. But to close the cleft palate per se, no bone graft is used. All right. Any other question? Welcome, my pleasure. If there are no further questions, can I log out?
Thank you, ma'am, and thank you all trainees for joining this session.
Thank you so much.